Good morning, everybody. My name is Peter Verdonk, working in Antwerp. I was invited by Philip to tell you a little bit more about injectables for knee OA. We will focus on microfragmented fat injections. Basically, we all know that OA is a biomechanical disease driven by inflammation, genetics, and load. And it's basically a whole joint inflammatory pathway. Currently, we see a lot of these patients walking into our clinic because we are confronted with the aging athletes. A number of them have structural OA in the above 65-year-old patient group. And so injections mainly focus on the inflammatory pathway in these knee joints. However, if you look into the OA treatment guidelines from all of these scientific societies, there's very little evidence or very little guidelines into the use of cortisone, hyaluronic acid, PRPs, and stem cell treatments or fat injections. So basically, where is the current evidence on these injectables and more specifically on the microfragmented fat injection? So if you're looking into the literature, into my patient population, my personal experience, my patients ask me two questions. The first question is, doctor, will I be better and what are the chances for being better? So that's a percentage of responders. And then they will ask myself, for how long will I be better? Will this be for 6 months, a year, 2 years, or for a lifetime? And so to answer that question, one particular methodology is of importance. You need to identify the response rate at a certain time point. And response rate is the percentage of patients with a minimally clinically significant improvement of on the Q score, about 10 points, or more complex but more definite is the OMRACT ORC response set. And so that is basically what we have been using in this study. But if you look into the literature, that is where all other studies basically lack evidence. So we are looking currently into the autologous microfragmented adipose tissue to treat symptomatic knee osteoarthritis. We're looking into the outcomes, clinical outcomes, and also potential prognosticators in a pretty large case series with a minimal follow-up of 12 months. And this is a very big effort that we have been doing for the last years. You can see here that most of my patients that I treat, I started treating patients with this treatment protocol almost now 3 years ago, but most of these patients will come in for a bilateral injection. That is also something very typical in this patient population. So the current treatment protocol for OA includes microfragmented fat tissue through liposuction. This is a single center, and I have been treating grade 1 to 4. So I always also have been treating bone-on-bone situations in my patients. We all know that these microfragmented fat is basically a fat parasite cell suspension for anti-inflammatory and structural effect. The big difference between this product and many other products is that this is a soft mechanical process, minimal manipulation, and you basically transfer tissue from one area, which is the belly fat, into the articular space, and that's basically what this product is. There are other products on the market, but they are more harsh, more radical, including centrifugation and enzymatic manipulation. And I think that's a very important difference. The study objectives were to evaluate the clinical progression, response rates, and safety of patients with diffuse knee osteoarthritis after a single injection with autologous microfragmented fat. And we wanted to establish patients, but also pathology criteria to improve the treatment selection. Basically, I want to know at the end of this study which patients will respond the best to this kind of treatment. We've been looking into our data, minimal follow-up 1 year. You can see that there was almost a 50-50% male, female. The average age in this population is about 55-year-old, and some of these patients are somewhat obese. Most of them have significant pain, as you can see on these profiles. If you look into the patient population and into their MRI criteria, you can see that almost 1/3 of these patients have advanced knee OA on the medial compartment or the patellofemoral compartment. A number of them, 1/3, had bone marrow lesions that were severe, and the majority had synovitis. So this is my all-comer patient population coming in for this type of treatment, and I've been looking into this kind of population who reacts best to this type of treatment. You can also see on the right that a number of these patients had meniscus tears, degenerative meniscus tears in the medial and or in the lateral compartment. If you look at my overall KOOS profile of my patient population, you can see that all of them are significantly improved still after 12 months. And remember, I have very little scientific data available in the literature looking into any type of injection with more than 12 months follow-up. So this is pretty interesting. You can see that there's still a significant improvement after 12 months in this patient population. If we break it down to patients that do respond, and I exclude the patients that do not respond, so the therapeutical response rate at 12 months is 45%. 45% of my patients are still positively better than at the baseline. However, if you are positively better, you can see that you improve by 30 points on the KOOS score. And the non-responders basically get worse, slightly worse over time. Absolute improvement also in the activities of daily life. You can see 45% is still better by an average of 30 points, and that is pretty interesting to observe. However, if we now start looking into some of these prognosticators, then what is very obvious is that the bone marrow lesion, so if you have no or mild bone marrow lesions, your therapeutical response rate increases to almost 70%. So if you have no or mild bone marrow lesions on the MRI, 70% of these patients will still be significantly better after 12 months. If you don't have any medial meniscus lesion, 56% or 57% of these patients will still be significantly better after 12 months. And so we believe that bone marrow lesions and medial meniscus horn lesions are prognosticators to identify patients that will benefit the most of this type of treatment. Take-home message is that overall, 45% of these patients, including bone-on-bone patients, are responding to a single MFAT injection at 12 months of follow-up. You can expect a peak effect around 3 months. In well-selected patients with no bone marrow lesions, 70% therapeutic response rate can be reached, and therefore I believe that MRI is important to identify these patients pre-injection, to identify the best responding group. There's likely some moderate inflammatory response after the injection, which takes about 2 to 4 weeks and then disappears. We haven't seen any serious adverse events, and prognosticators are posterior horn of the medial meniscus lesions and severe bone marrow lesions. If you exclude those, you can see a better therapeutic response rate. So basically, microfragmented fat is homologous tissue transfer from the belly fat into the knee joint. It's a safe procedure. It can be done outpatient. In our center, it takes about 1 hour to treat these patients. And for now, my experience is that this is the best in-class response rate at 12 months. If I compare this with any other PRP, any other hyaluronic acid, any other cortisone steroid injection paper, this is the best data that I have observed at 12 months and further on. Thank you very much for your attention.